Next speaker will be Dr. Mohammed Haddad. Dr. Mohammed is Director of Endoscopy Digestive Disease Institute, Cleveland Clinic, Abu Dhabi. Emirate. He will speak about the approach to incidence pancreatitis cyst, his follow-up and monitoring necessary. Welcome, Dr. Mohammed.
Assalamu alaikum wa rahmatullah. Esteemed chairpersons, ladies and gentlemen, I'd like to extend my sincere thanks to the SGA for the kind invitation. Special thanks to my dear friend Dr. Majid Al-Madi for reaching out to me to be here today and present to you today and tomorrow. Today we'll talk about approach to pancreatic cysts and help decipher some of the recent confusion in regards to the management of cysts, which I think has been augmented by some of the recent guidelines that have been recently published. So I will start off with a case. This is a case I've seen a few years ago, several years ago actually, 55-year-old female patient who had an incidental finding of a small cyst measuring 1.5 centimeters on the tail of the pancreas on imaging. She had no family history of pancreatic disease and no history of pancreatitis. As you can see on the MRCP, on the MRI, there's a small cyst in the tail of the pancreas, and there's a small ductal communication, as you can see on the EUS image. So the patient was referred subsequently to EUS, where cytology showed some extracellular mucin, but no mucinous epithelium. However, the CEA was in the gray zone or borderline of 176. At the time I had access to molecular analysis, I was able to send some fluid off, and I got a KRAS positive local analysis mutation, indicating that this is very, very likely a small mucinous cyst. In this case, it would be a side branch IPM, and given the morphology. So pancreatic cyst is a very common thing we deal with these days. We go through stages of detection initially, typically these days on imaging, which is typically done for other reasons, or patients may be symptomatic. Subsequently, patients undergo further imaging with CT and MR, and very often referred to endoscopic ultrasound. And finally, we obtain cytology tumor markers. Hopefully, we're able to make a diagnosis, and then we go on to the management phase. And we have a couple of options. Either we pursue conservative management in the majority of cysts. In a small group of patients, we send them for surgical resection. I think you would all agree with me that we're dealing with an epidemic of pancreatic cysts. On some of the autopsy studies, as high as 24% had cysts in the pancreas. From MRI studies, we know it could be as high as 14%. And we ran our own study a few years back that showed up to 10% or so of patients presenting for EUS for other or non-pancreatic indications, in fact, had incidental pancreatic cysts. So this is a very common thing. Today, I will not discuss the inflammatory cysts. Dr. Deer on the next talk will talk about this. I will focus on the epithelial or true pancreatic cyst, represented by MCNs or mucinous cystic neoplasms and IPMNs, in addition to serous cysts. We have also rare other types of cysts, including cysts that come as a result of tumor degeneration, and also the rare lymphoepithelial squamous cysts. So IPMN probably is the most common cyst that we see incidentally these days, especially the side branch variants. As you know, from a morphological and pathological standpoint, these cysts come in three flavors. We have the main duct type, which you see to the right of the screen, with no side branch involvement. We have diffuse main duct or segmental main duct involvement, or we have the branch duct, which you see on the left side of the screen, which is typically involving one of the side branches of the duct, or you have the mixed variant in the middle where both the main duct and the side branches are affected or are involved. These are classic endoscopic features of main duct IPMN, showing a gaping papilla with mucin exuding from the papilla due to presence of large amounts of mucin. On the lower left side of the screen, you see also the fish egg appearance, which is a classic feature of main duct IPMN, in this case, coming right through the papilla. And we actually biopsied this one, and it was a mucinous epithelium. When you resect IPMN, you see a main duct involvement like this one. You see classic mucinous epithelium with variable degrees of dysplasia on lining the inner side of the duct. This is a side branch IPMN that had low-grade dysplasia and no associated nodules or mass lesions. Mucinous cystic neoplasms also can resemble side branch IPMNs, although they affect the tail of the pancreas more often than not, and they typically tend to be a little bit larger at the time of diagnosis. The mucinous cystic neoplasms, which we can be also unilocular, multilocular, they can have septations and even some calcifications on the outside. They call it the eggshell appearance. They can have microcalcifications and some of the septations as well, as you can see in this picture. And the pathological hallmark is the presence of ovarian stroma under the columnar epithelium, which is typically obtained after resection and pathological examination of the specimen. Now, serous cystic neoplasms can also present in multiple morphological variants. The one that we are probably most familiar with is the honeycomb's appearance of a microcystic serous cyst adenoma, which we see on the right lower corner of the screen. But they can also be unilocular, as the one you see to the left, which only one big cavity, which can resemble an MCN in this case. But they also can have the oligocystic variant, where you have 3, 4, 5 different compartments, as we can see in the right upper side of the screen. The pathological diagnosis of serous cyst adenoma can be confirmed on, obviously, apsial resection, where you see low-height cuboidal epithelium lining these cystic spaces, which is glycogen-rich in this case, and this is a cross-section through one of the lesions, which demonstrates the classic central calcifications or dense fibrous tissue on imaging commonly referred to as sunburst appearance. This is a busy slide, but the take-home point is that we see IPMNs in older patients. We see MCNs in females more than males and typically affect the tail and the body of the pancreas. And serous cystic neoplasm can affect also older patients, slightly more females than males, and they all have different pathological, obviously, diagnostic features upon resection. So once we make a diagnosis of a cyst or detection of a cyst, the most important two questions are, A, is it mucinous or non-mucinous? B, if it's mucinous, is it benign or malignant? Or in what phase of evolution is that cyst is? And do we rely only on imaging, or should we pursue EUS and other tissue sampling techniques like FNA, or do we send the patient directly to surgery? These are very difficult questions, and I cannot claim that in 2016 we have satisfying answers to many of them. Most of us eventually do EUS and we sample these cysts because it's relatively safe and easy to sample cysts. So what do we get? We get fluid, which we can check for the presence of mucin. Most of us would also say that at this point we should all be checking for CEA because it does help us affect or make a diagnosis. If it's elevated more than 192, makes the probability of a mucinous cyst higher. We can check amylase, which tends to be high in some side branch and main duct IPMNs and also in inflammatory cysts. And we can check viscosity with the string sign if you still do it. Typically, the mucinous cyst will have a higher viscosity. The serous cyst will have a more fluid type of consistency. So can we rely only on imaging? The answer is no. As you can see from multiple studies, to rely only on imaging to diagnose the cyst is inadequate and only gives you the right diagnosis in about half of the time. It's like a flip of a coin, basically. If you do EUS and combined with FNA, you do get a little bit more bang for the buck in terms of increasing your diagnostic accuracy from about 50% relying on imaging alone up to 70% if you combine the findings of the fluid analysis like CA and cytology, and this has been supported by multiple studies over and over again. So there is a role for the diagnostic part of EUS FNA in this case. So how do we manage these cysts? And this is a very difficult topic. Still, we're struggling with a lot of guidelines. As you can see, we have 4 of them now in literature. I would venture out to say that the Fukuoka guidelines, which is an update of the initial Sendai guidelines published back in 2006, the Fukuoka came and updated that in 2012, which is probably the most widely accepted guidelines these days. The American Gastroenterology Association came out with the recent guidelines that you may have seen in gastroenterology in the spring of 2015, which is very highly controversial at this point, and so far it's not widely accepted due to some of the limitations I will highlight in the subsequent slides, and also the radiologist colleagues, they have their own guidelines as well that they stick to. So why are we so interested in managing these cysts more than we do for example, kidney cysts or liver cysts? Well, the answer is simple, because the risk of cancer in mucinous cysts is there. For example, in main duct IPMNs, based on some surgical literature, the risk can be as high as 50%. For the mucinous cystic neoplasm, the risk can be as high as 20%, although the natural history is not quite clear for the small lesions. For the smaller branch IPMNs, the risk is not known. I would say that 10 to 20% is an inflated risk that we see in the literature. From my experience, it's probably under 5% if you take all comers. However, as I said, literature is biased by the fact that it only studied those who went to surgery, which I think is clearly a skewed population. Let's examine a little bit the consensus guidelines published by the group, by Tanaka and his group, and the consensus actually was in pancreatology in 2012. For all main duct IPMN, the indication, the recommendation is to send them to surgery if they are fit, just because of the high risk of invasive disease and overall a low 5-year mortality. We have had some data showing that small size main duct disease, less than 8 millimeter in size, might have a more favorable prognosis, and you might be able to watch these patients if they have a main duct of 6 to 8 millimeter in size, but there's a need for more data to enforce that statement. We still don't know much about what happens when we see segmental main duct dilation associated with branch duct disease without pathological main duct disease, and we have seen this recently in a paper that we're publishing this year in the GIE, that these patients tend to also behave in a much more benign fashion because they simply may look like they have main duct disease, but they really have just segmental dilation with no pathological main duct disease. It just happened to be adjacent to a small side branch that is dilated. For MCNs, the guidelines tell us that for all surgically fit patients, they should go to surgery. Remember, these are typically females. They are younger. They're typically in 3rd, 4th, and 5th decades, and you do not want to survey these patients for a very long time because of risk of loss to follow-up or potentially exposure to radiation if you use CT and such. So you should send these to surgery as much as you can. For the branch duct IPMNs, this is where the controversy will evolve, and you'll see that over the next several slides. There is clear consensus right now. If you would like or you should resect a branch duct IPMN, it's typically done in patients who come to you with jaundice, or they have an enhancing a solid component within the cyst, and those who have main duct dilation, particularly the mixed type, which appears to have or to carry a higher risk of overall malignancy than either of the other two types isolated. In addition, the guidelines tell us that we should pursue or strongly consider surgery in some other situations they deemed as worrisome. What is a worrisome feature, basically, in a cyst? History of pancreatitis, cyst more than 3 centimeters in size, thickened walls, main duct between 5 and 9. Remember, this is the sort of the more favorable main duct size that we talked about. Non-enhancing mural nodule, which some of those could represent just mucin in the cyst, in addition to abrupt change to the caliber of the main duct. We saw a case yesterday, actually in the live course, where the patient had an abrupt change in the caliber, and the recommendation was to have a surgeon see this patient as soon as possible. Also, if you see anything on EUS, like a definite mural nodule or suspected main duct involvement or cytology that is suspicious, you should send these patients also to surgery. Now, the AGA guidelines, I'm not sure how many of you had the chance to really thoroughly examine these guidelines, but I will highlight a couple of things I'm very uncomfortable with in terms of following these guidelines. So if you look at the guidelines, they tell you that pancreatic cysts that are less than 3 centimeters in size without high-risk features, you can survey them initially at year 1, then every 2 years for a total of 5 years, and then you can quit altogether. I'm not sure how many of you would be comfortable letting a patient go after 5 years without doing any follow-up exam from that point onwards. As a matter of fact, they suggest against continued surveillance of these cysts. There have been no changes in the initial 5 years after you diagnose that, which I think is certainly an understatement to and potentially could miss some cancers. So in these situations, does EUS really help you? If you talk to the surgeons, a lot of my surgical colleagues did not believe much in FNA or EUS, and they tell you I can decide based on imaging alone if I need to take the patient to surgery or not. But I can tell you, if you already made your mind that you're going to resect this MCN in a young female patient, there's no need for EUS. You already made the decision, no need to waste resources and time and complicate things. However, if you have a cyst that's 3 centimeters in size or larger, you have changes in the duct caliber, you suspect a nodule, I strongly endorse that you do EUS in this specific case. because that might sway your decision from one point to another and might help convince the patient to undergo surgery if you see additional features on EUS that you have not seen on other imaging. In addition, I can tell you from my own experience and from a study that we're also publishing in a short interval is that EUS will detect more mural nodules than CT and MRI even combined. The small nodules under 6 mm in size are not going to be very easily seen in MRI. You're likely going to miss them unless you do EUS. Also, you will probably not appreciate main duct size that's typically between the 5 and 9 mm range. As well. Now, EUS features can, especially mural nodules, main duct involvement, and positive cytology, in our study were highly, highly accurate and specific for malignant branch duct IPMNs. So these are the features to focus on when you do your EUS exam of these patients. Also, you can use EUS to follow your patients after resection to make sure they do not develop recurrence, and we know now that most recurrences will happen after resection of malignant, not benign, IPMN. I can safely say that after benign resection or resection of benign IPMN, you can let the patient go for prolonged intervals without having to survey them as much as you need to if they were malignant. So what's the problem with all these guidelines? I don't think any of them is perfect or near perfection at this point in time. First of all, they have suboptimal negative predictive value, which means you will miss malignancy at times. We have several studies showing that there's up to 3% risk of progression to malignancy beyond 5 years in all comers in side branch IPMN, so that's not a small risk to really be missing. And also, there's up to 17% advanced neoplasia risk in cysts otherwise deemed low risk by recent guidelines. I've had the chance to review multiple abstracts for the upcoming DW, and I can tell you that especially quitting the surveillance after 5 years will probably might be a dangerous practice, especially if your cancer risk can be up to 5% beyond that point. And the other problem with these guidelines, obviously, is a suboptimal negative predictive value. So they do not prevent unnecessary resection in that case. And the other thing, I'm an endosonographer, so I like to do FNA, and I see that all these guidelines have totally sidelined the fluid analysis. None of them really relies much besides cytology on new molecular markers, CEA, or even some of the more investigational tests that we will have coming in the next 5 to 10 years. So it's a balance between negative and positive predictive value, and in my opinion, what guidelines you choose to follow these patients, it will be important to determine the acceptable rate of false positives in order to prevent a single true positive. So in my experience, or my opinion, if you have to follow 100 patients for 5 years to prevent one pancreas cancer, in my opinion, this is justifiable. Now, this is not based on any cost effectiveness analysis or any modeling, although some have tried to do it. However, I do believe, given how deadly and rapidly spreading pancreas cancer can be, that if you follow 100 patients to prevent 1 or 2 cancers in 5 years, that's still a lot to be gained. So what's next? I think guidelines are unlikely to perfect patient selection for surgery versus surveillance unless it will adopt fluid analysis, and I think this has been totally ignored in all these guidelines I showed you. There's a growing role of molecular analysis. I think 10 years from now, we'll be talking about a very specific marker in cyst fluid that will tell you if this cyst will progress or will not progress, and will help you make a decision to resect it early on or not resect it, and potentially even let the patient completely be released from surveillance if that marker is not present in the cyst fluid. Are we there yet? We're not there yet. I strongly believe we'll be there probably in the next 10 years or so. Going back to our patient, the patient that we presented earlier, we made diagnosis of side branch IPMN, incidental asymptomatic side branch IPMN. The patient opted to be followed initially annually, then MRI, MRCP, which I like to alternate with EUS in a lot of these patients year in, year out. So 1 year EUS, 1 year MRI. After 5 years, there was still no progression. The patient will continue to be surveyed from that point on as well. However, I agree that you can probably relax your surveillance from annually to every other year, but do not release this patient completely out of your surveillance program. So in conclusion, cyst morphology on EUS or other imaging is not accurate alone for classifying the cyst. Cyst fluid will help you, especially cytology. It's very insensitive, however, it is highly specific. Cyst fluid CEA is reasonably accurate for classification of mucinous cysts, but not malignancy. Some tell me if a CEA comes back 20,000, is this malignant cyst? I would tell them, no, there's nothing to support that. Although we've seen a few reports, but overall there's nothing to convince us that this is a marker of malignancy. Combining cytology CEA and some of the new molecular markers, especially KRAS mutation, will help you more accurately determine which cysts are mucinous and the need to follow these cysts. Obviously, like anything else, pancreatic cyst is a very difficult topic to study and evaluate. I highly recommend a multidisciplinary approach to the management of these cysts. The team we have, or I had before in my previous job, included also obviously a surgeon, a dedicated radiologist, a pathologist, and also an interventional gastroenterologist, endosonographer, and we met regularly to render opinion on a lot of these difficult patients. So this is a very good thing to have if you have access to a multidisciplinary team. I thank you very much for your kind attention.